Bismillahirrahmanirrahim. Quote of the day: patient is a pillar of faith. Today's topic of presentation is disease surveillance. I'm Dr. Iqbal, PGR Community Medicine, and I'm presenting under the supervision of Professor Dr. Saira Afzal. So, first of all, definition: it is a systematic, continuous collection, analysis, and interpretation of health data, followed by dissemination of to those who need it, public health action. First step is the collection of the data and then an analysis, interpretation, and then dissemination. This is a continuous feedback loop for public health action. The historical background first is that John Snow in 1954 mapped cholera cases to identify contaminated broad streets pump birth of epidemiological surveillance. Second is vital statistics system, birth and data registration improved capacity to track disease burden across population. National surveillance program 20th century saw emergency of formal diseases reporting system in the industrial nation. Fourth one is the modern digital era, real-time global digital monitoring, including AI-driven predictive tool and international framework. The objective of surveillance are early outbreak detection, identify unusual clustering of disease event, and trigger rapid investigation and response. Monitor disease trend, track increases and decline over time to understand population level disease burden. Identify high risk group, target intervention towards the vulnerable population for maximum public health impact. Guide policy and evaluate program, provide evidence base for health policy and measure effectiveness of ongoing intervention. The key component of surveillance are data collection, getting health data from the hospitals, laboratories, community, and registries, and then data analysis, applying statistical and epidemiological method to identify pattern and anomalies. And then interpretation, understand implication of trend within the epidemiological and conceptual framework. And then dissemination, sharing the finding via report, alerts, alert to decision maker and practitioner. And then action, implementing evidence-based public health response based on surveillance findings. Next, the types of surveillance types are passive surveillance, active surveillance, sanitary surveillance, syndromic surveillance, event-based surveillance. Now we'll discuss this one by one. Passive surveillance is rely on a routine facility report, cover large geographical area. Low resource requirement under reporting is a major limitation good for common notifiable disease. Active surveillance, health authorities actively collect data, regular outreach to health facility, higher sensitivity and completeness, resource intensive, required funding, used for elimination and eradication goal. Next is the sentinel surveillance, which is selected institution report data, representative sampling approach, excellent for trend monitoring, not population-wide coverage. For example, influenza sentinel site. Syndromic surveillance are based on clinical symptoms only, early detection before lab confirmation, rapid data collection in the emergencies, less specific, for example, ER visit with ILR symptoms. Next is the event-based surveillance, which is used in formal sources like media reports, rumor, community alerts, social media, designed to detect unusual health events before formal system triggers. Serve as an early warning system complementing routine surveillance, require verification before action. Risk of false alarm is significant. WHO Global Outbreak Alert and Response Network is a key example. Widely used during COVID-19 for rapid signal detection globally. Next is the indicator-based surveillance, surveillance based on predefined indicator and standard case definition. It is used routine structure reporting for health facility, collect quantitative data regularly, weekly, daily, weekly, and monthly disease reporting, usual for monitoring disease trend and burden. It's for planning, policy making, and outbreak detection. For example, TB notification, polio surveillance, COVID-19, confirmed cases reporting. Next is the data source in surveillance. Hospital and clinics, primary report unit, inpatient admission, outpatient consultation, and emergency visit. laboratories that confirm diagnosis with microbiological and serological testing for accuracy. While vital registration, birth and death registration system essential for mortality and cause of death data. Survey and registries, population-based survey, cancer registries, TB, HIV registries for specific disease tracking. Next is attributes of good surveillance system. Simplicity, easy to operate and understand, flexibility, adapt to new threats, sensitivity, detect true cases accurately, specificity, exclude known cases reliably, timelessness, rapid detection and reporting, representativeness, reflect true population, acceptability, willing participation by a stakeholder. Next is the evaluation of surveillance system. Assess usefulness. Does the system guide meaningful public health action? Measure performance against key attributes like sensitivity, timelessness, etc. Identify gap. Where do failure is detected or reporting occur? Evaluate resource utilization, ensure representativeness, and regular evaluation ensure continued relevance and adaptability of the system. So this is the surveillance cycle in which first of all we collect the data and then analyze and then interpretation of that data in dissemination and action took place. This is a continuous feedback loop. This is the data flow in the surveillance system. First of all, the reports and data collected from the community moves to the health facility and then district health office toward the zonal health department, then regional public health institute, and then at the end national public institute, where the policies and feedback move back to the community. So this is the data flow in the surveillance system. Next is the epidemiological indicators used. So a frequency measure indicator incidence rate, new cases per population per unit time, prevalence rate by all existing cases at a given time, attack rate, proportion affected during an outbreak, secondary attack rate spread within the household. Next, severity and burden by mortality rate, death due to disease per population, case fatality rate, death among confirmed cases, year of life loss, burden of the premature death, disability, adjusted life year, overall burden. So next is the surveillance versus monitoring and versus evaluation. So surveillance is the continuous data collection, population health focus, detect trends and outbreak, long-term ongoing process, and external and disease-oriented. Whereas monitoring is the ongoing program tracking, input, output focus, track program progress, regular periodic interval. Internal program, so it is internal and program oriented. Whereas evaluation is the periodic outcome assessment, impact and effectiveness focus, measure goal achievement, point in time assessment, result oriented judgment. Next is the integrated and the global surveillance. Integrated disease surveillance and response. Combined monitoring of multiple disease into a single coordinated system, WHO IDSR strategy widely implemented in Africa and other developing countries. Efficient resource use, shared infrastructure, reduce duplication, strengthen national health system and laboratory network, enable rapid response through standardized case definition and threshold, improve coordination between disease control program and the public health agencies. Next is the global surveillance system. So the global surveillance system include WHO, Global Outbreak Alert and Response Network, which is rapid international response to the public health emergency. CDC surveillance program, which is the advanced epidemiological tracking system in US, shared globally via the FluNet and other platforms. International health regulation, legal framework for the global health security, 196 countries obligated to detect and report health events. Next is the global platform for sharing the pathogen genomic data, which is critical during the COVID-19 and influenza season. A surveillance system in Pakistan, NIH, National Institute of Health, Islamabad, Central Coordinating and the Reference Laboratory Body, Disease Early Warning System, which is due deploy in a conflict and post-disaster setting for early detection. Expanded program on immunization, track vaccine preventable diseases, polio surveillance in a priority. Provisional disease surveillance system and response unit at the provisional level, digital platform being piloted to improve the real-time data flow to the federal level. So this is the disease surveillance system. In recent Pakistan, especially the province of Punjab, that has recorded an upsurge of vector-borne diseases like dengue. So the system has been operational since 2013. Data surveillance is being captured from the across the Punjab and from all level of healthcare facility, that is primary, secondary, and tertiary. 147 hospital. Detected data entry operator equipped with laptops, internet connectivity has been tasked to report case from the public hospital across the province. So the BHOs and RHC are reported disease case via SMS with the help of disease wheel. Recently, these facilities were provided tablet to ensure that within a relatively short period. So this is the disease calendar based on data historically available in the disease surveillance system. Health department has put together this disease calendar. The calendar highlight the alert of the peak month for all the communicable diseases. So this is another diagram showing the disease surveillance system. This is the dengue activity tracking dashboard. Next is the digital and the modern surveillance. Digital and the modern surveillance include electronic health record, faster data sharing, and integration across the health facilities for near real-time surveillance. Mobile-based reporting, field workers submit data via apps used in polio eradication and malaria program. AI-based and the big data analytics predicting modeling of outbreak using large data set anomaly detection and algorithm. COVID-19 dashboards, real-time national and global tracking becomes standard model for future emergency surveillance. Next is the role of surveillance in the outbreak investigation. The first step is detect the unusual increase. Surveillance trigger the investigation when case count exceed epidemic threshold. Then confirm diagnosis, laboratory confirmation of the pathogen, and then identify the source and transmission and implementation, the control measure, and then communicate and evaluate. So this is a diagram showing in which symptomatic cases are the case proceed syndromic surveillance, and that is information on the emergency department, visit and medication, etc. Or disease treated or suspected by the healthcare provider. Then move to the local or the state health departments, if, investigate by the public health laboratories, and then additional investigation done. If the something unnatural region, then it notify others, for example, local and state and federal law enforcement and emergency management official, and then continue outbreak investigation and response. Next is the ethical issue in surveillance. Individual right confidentiality, protect patient identity in all reporting, data security, prevent unauthorized access or misuse, stigmatization, risk, and equity. Surveillance must serve all population fairly. Collective responsibility, informed consent required where the applicable by law. Privacy versus public safety, transparency. Community should know what is collected. Accountability, data should be used for the stated purpose only. Next is the challenges in the surveillance. Under-reporting many cases never reach the surveillance system, especially in the rural areas. Lack of trained workforce, poor data collective quality, and inconsistent reporting practice. Delay reporting, late response due to the slow data flow from the peripheral facilities. Resource constraint, financial and technical limitation in the low income settings. Political wills, reluctance to report outbreak due to trade, travel, or reputational concern. Next is the data silos, lack of interoperability between the different health information systems. Strengthening surveillance system by capacity building, train healthcare worker in the case detection, reporting, and data collectivity at all levels. Laboratory network development, strengthen the diagnostic capacity for accurate and timely pathogen identification. Digitalization, implement electronic reporting system to reduce delay and improve data quality. Community involvement, engage communities as the active participant for improved detection and compliance. So next is the emerging trends and applications. Emerging trends in surveillance, genomic surveillance, whole genome sequence to track pathogen variant. One health approach, integrated human, animal, and environmental health surveillance, real-time dashboard, instant data visualization for decision makers at all levels, artificial intelligence, machine learning for outbreak prediction and anomaly detection, social media meaning infodemic monitoring and informal signal detection, wastewater epidemiology detecting the pathogen in the wastewater before clinical case emerge. Next are the applications of surveillance, communicable diseases, infectious diseases like TB, malaria, COVID-19, HIV, dengue, polio, vaccine preventable diseases, EPI monitoring, coverage survey, antimicrobial resistance, which in MRI tracking in the clinical setting, AMR tracking in the clinical setting, and emerging infections. Non-communicable and other non-communicable diseases like cancer, history, cardiovascular, and diabetes. Environmental health, occupational health include workplace hazard surveillance, injury and trauma include road traffic accident and violence data. Next is the case study that is COVID-19 pandemic. What is COVID-19 taught us about surveillance? Real-time genomic surveillance enable rapid identification of new variant Alpha, Delta, and Omicron. Event-based surveillance ProMed WHO e-based detecting early signal before official report. Digital dashboard become global tool for tracking and decision making. International coordination gap. IHR compliance varied significantly between the countries. Wastewater surveillance emerged as a powerful complementary early warning tool. So invest in the surveillance infrastructure before the next pandemic, not during it. So the conclusion of this is effective surveillance save lives. Strong surveillance system requires sustained investment in the workforce, technology, laboratory capacity, and political commitment, especially in the developing countries. Collaboration from the local or the global level is not operational. It is essential. So this is the reference from the presentation. Next is we'll discuss the MCQs. First one is a district health officer noticed a sudden increase in acute watery diarrhea cases reported weekly through the routine hospital reports. No active case finding is done. What type of surveillance is being used? A. Active surveillance. B. Sentinel surveillance. C. Passive surveillance. D. Syndromic surveillance. E. Event-based surveillance.
C. Passive surveillance.
Yes, C is the right option. Aptitude number second. During a dengue outbreak, health team visit household daily to identify the few cases, fewer cases. What type of surveillance is that? A passive, B active, C sentinel, D event based, E laboratory based.
D. Active.
Yes, B is the right option. MCQ number 3. Selected hospital across the province report influenza cases to monitor seasonal trend. This is an example of A. Active surveillance, B. Passive surveillance, C. Sentinel surveillance, E. Syndromic surveillance, E. Integrated surveillance.
C.
Yes,
Sentinel.
C. Yes, C is the right option. MCQ number 4. Health authority identify the disease outbreak after monitoring new and social media report. This is passive surveillance, B. Active surveillance, C. Sentinel surveillance, D. Event-based, E. Laboratory. So D is the right option. MCQ number 5. D is the right option. MCQ number 5. A surveillance system failed to detect many true cases of tuberculosis. Which attribute is compromised? A. Specificity. B. Sensitivity. C. Timelessness. D. Flexibility. E. Susceptibility.
B. Sensitivity.
Yes, B is the right option. MCQ number 6. Country combined report of TB, malaria, and measles into a single system. This is A. Passive surveillance. B. Active surveillance. C. Integrated surveillance. D. Sentinel surveillance. E. Event-based surveillance.
C. Integrated.
Yes, C is the right option. MCQ number 7 is zoonotic disease surveillance system, integrated animal and human data. This approach is called A. Passive surveillance, B. Active surveillance, C. One health approach, D. Sentinel surveillance, E. Event-based surveillance.
One health approach.
C.
Yes,
C.
C is
One
the
health
right.
approach.
Yes, C is the right option. MCQ number 8. During the evaluation, a surveillance system is found to detect outbreak quickly but fail to capture rural population adequately. Which two attributes are involved? A is sensitivity and specificity. B, timelessness and representativeness. C, flexibility and simplicity. D, accountability and stability. E, sensitivity and timelessness.
B.
B.
Yes, B is the right option. MCQ number 9. A surveillance system show a stable number of report malaria cases over time, but independent survey reveal a rising true incident. What is the most likely issue? A, high sensitivity. B, high specificity. C, underreporting. D, overdiagnostic. E, improved surveillance.
D.
C is the right option, underreporting. MCQ number 10, during an outbreak, authorities rely on emergency department data showing fewer cases to trigger alert before lab confirmation. Which is the main advantage of this approach? A, high specificity. B, cost effectiveness. C, early detection. D, representativeness. E, stability.
Early detection.
A.
C is the right option, early detection. So this is the answer key. It's a YouTube channel where the recording of this presentation will be uploaded. Thank you.
Thank you so much, Dr. Rabbia.